This evening, we have a very important topic to discuss. A very important topic because it is of public health concern. And if we have an expert to demystify this vaccine we are going to give to our girls, I think it is very important that we pay attention. And we are privileged this evening to have with us a senior lecturer of the Department of Obs and Gynae, School of Medical Sciences. They are normally affiliated to Kwabena Teaching Hospital. And he is the acting head of the Gynecologic Oncology Department. Since he is into oncology, then you all agree with me that he's somebody who has a lot of passion relating to issues concerning cervical cancer. And so if we have him here to talk to us on bridging science and myth to protect our future, parental confidence in the human papilloma virus vaccination in Ghana, I think that we have the best person to speak to us this evening. So let us stay tuned. Let us pay attention as we listen to Dr. Kwabena Amo-Antwi. Dr. Amo-Antwi, you are welcome.
Thank you. Can I be heard?
To listen to you.
Can I be
Thank
heard?
you.
Yes. Thank you, ma. Thanks for that wonderful intro. Professor Mrs. Opariado. In our journey to have a disease-free society, our prospects have changed from having so much burden with essentially diseases that were infective in origin. As we develop as a nation and a society, having so much of disposable cash, we are seeing reducing numbers of infective diseases. But on the contrary, there are aspects that are still plaguing us, and now we're increasingly getting to know that there are viruses and other, let me put it, inanimate particles that are plaguing us as people. One of such things we would want to talk about has to be the human papilloma virus. The conundrum with this has to do with the fact that is essentially infective in origin. And the moment you talk about them, how do you get it? Those that harm us most, we get them through sex. But that has been our also source of what the bane, with which every parent would not want to kind of have a discussion around that because my kids are not having sex. We are not talking about sex. We are talking about things that can damage them in the future. In Ghana, the median age at first intercourse is around 17 and a half years. And that, whether we like it or not, that aspect of our social integrated behavior will start with us, with our kids, our nieces, our nephews, and it's become a puzzle of the egg and the chicken. Which one came first? So for me, I need to bring us to the realization that for us that live every day with, the ramifications of the human papilloma, as a parent, and the fact that I deal with this every day, I need to also bring my expertise on board. That led to us knowing a bit about this, the reality, that's the science. And then the apprehensions, they have horse, they have human, impressions we have about these things in our mind that is negating against the fact that in the contemporary sense of the global agenda for women health, what is it that can protect our women in the future? When women, we talk about women. Intrinsically, we have men issues that also are protected. Now, for me to do this or lead the discussion, I have no conflict of interest. And this subject, I come to you as someone with, let's say, a bit of proficiency, and that I can really be able to handle majority of questions thrown at me in that aspect of what my work dispensation. As a matter of fact, if I need to demystify the link between science with, in terms of issues around HPV, I will start to feel everyone who knows me, I don't talk about textbook. I talk about what I do every day, and then my deep understanding of them that shapes my teaching or my work with the university and then the society which I'm responsible to. I can tell you about 4 years ago, I had this 22-year-old university student. She came to me with vaginal discharge. And I can tell you, whether you are a young girl, a premenopausal, prepubertal, you've never had your menses, you've had your menses and it's gone. If you have any troublesome vaginal discharge, the person who sees you should be able to examine your vagina. But for those that have not had sex, we have a way of doing it. When I examined this girl, if you could look at the upper right corner of my slides, I passed a speculum so that I can visualize the cervix or look at the cervix very well. And I realized that there was this kind of dark lesion or black substance on the cervix. This is a very innocent cervix, so I took a bit at age 22. When you see anything that is not like the tissues that are resident in that area, you need to investigate as to what is causing it. And it came out, unfortunately, as cervical cancer at 22 years. And this is a disease that the mean age often what we see at the hospital is 52 years. So now, we went through a lot of a battle trying to even get the parent to understand, the university student to understand that the cervical cancer, in this case, we could have done what we call trachelectomy, take a lot of those tissue with a healthy margin, and then maybe open her up, do a bit of lymph node, go through up to let's say, the generator that supplies electricity to the house, situated, and find out whether there are any issues with them. They did not bother. This girl came about 17 months down the line. And you can see at the right left quadrant, the disease feels everywhere in the vagina. And this time, we did a cross-sectional imaging. We sort of used something that we call a CT scan to look through the whole of the abdomen. And we realized that the disease has spread. This girl died at 25 years. There's no mystery about this. There's so much we know about this condition, and in that it's infective in origin. We know so much about this disease that the moment you have sex, within 2 years of your sexual debut, the carrier rate is over 70%. And it's been known with us, been established since 1985, that there's a real, connection between this human papilloma and cervical cancer. There are a few kind of concerning issues about us. The twist has to do with the fact that there's a high level of infection in our society, virtually in majority of the global south. It has to do with our first age at sexual intercourse, and then at pregnancy, and then the fact that there are no population-based interventions that prevent the establishment or the persistence of this HPV infection. And then if you look at Ghana, Ghana's case is not different. So it becomes a bit of what? A clarion call, response to a clarion call that, through the initiative of Global Vaccine Alliance, Ghana will be conscripted into a group of countries that are privileged to have that vaccine at the level of the population, but this time is supported by a lot of people. Elsewhere in the resource endowed societies, they have them. It's a privilege for all girls, right from 9 years to have them. And if you look at this twist, with high, even global average is 19.2. Africa is 43.9. The research I did at Konfonochi put it almost around the same 43 up to like 48. So for us to lose a 22-year-old girl to cervical cancer, then it means that there's something that we need to kind of be a bit aggressive in terms of the language we use around it. I always have this kind of statement I make. The only time you realize that what we're talking about is very close is when someone very close to you is a victim. If there are inner city suburbs that you realize that in terms of the way our younger generations are behaving in terms of where sex is becoming an everyday, it's becoming a venture for some girls in the settler communities. If it happens like that, for our innocent, or let's say, us who are trying to strive and then give almost everything, and then there's a spare for these our girls, then the bank that is developing in the, let's say, the less privileged suburbs, it's just a matter of time. The pool is transferred onto those that we care so much about. It could be not by purpose or design, but just that the population, when we talk about population, the population is just not limited to your kids. It's limited or is bounded by almost every suburb that you know that contains girls. And I need to come clear again. Issue of human papilloma, your girl may be innocent, but there can be a vector. The vector is the one that communicates between the population that your girl resides in and then the other population, whoever communicates between the two. And I hope it got to be understood that way. HPV is quite a troublesome stuff. Akonfonoche, it can give you cancer of the tongue, the mouth, you can have the skin, and then you can, everywhere that you have the squame. The squame is, like say, a pigmented skin. HPV can be resident there. It can be on your neck, it could be your throat, it can be anywhere. And for that reason, I set out, based on my few initial publications, I set out to find out if you had cancer, which is a cervical cancer, that is my discipline, how long would you live? And I realized that based on our difficulties we have as a nation, if I have 10 cases today, only about 4 of them will survive for 3 years. And that is quite a serious issue to grapple with. And for that reason, we need to have it as a serious public health, issue. But hey, for us growing up in we call the Gen Y generation, we realize that there could be, or there's been a glimmer of hope in the late 70s coming. 78 was when finally the expanded program of immunization, kids are taken to the hospital to have, let's say, a specialized road to health clinic. I remember I was taken to, my mom had me at Bechim. I was taken to Techimentia. Then the Techimentia clinic was very a strong one. At the initial inception, there were only about 6 conditions that the EPI was targeting. In 2022, there was a need for us to add hepatitis B and Haemophilus influenza. These are conditions that often plague the under 5-year population group. 2012 and 2013, there were reasons and scientifically based discussions to increase the repertoire of conditions that the Ghana Expanded Program of Immunization had. And I think that if you look at the card on my left, it's something almost everyone is familiar with. Has there been a reason why we would not take our kids to have the scheduled vaccinations under the EPI? There are, let's say, there is an avenue or a vehicle under the EPI that even comes to our area to vaccinate our kids, come to the school education program. There are a whole lot of them. But we discuss as a nation that looking at the morbidities and mortalities around cervical cancer, and it's not as if cervical cancer is only the disease that the HPV is intending to protect. The cancer of the throat, the cancer of the skin, the cancer of the anorectal area or the rectum or the anus, all of them can be etiologically or causally, traced to HPV virus. Then it's time to reason. This is not new with us. If for about 3-4 generations of the vaccine, we've increased them at, specific point, then we can add HPV vaccination to our EPI program. For parents, we should not be worried. Has there been any issue with the weighing that we take, that is the term we use, the weighing we take our kids to, or our infants to? If that is the case, then someone should tell us what. It's true that you bring your kids from weighing and then there's a mild fever. At times they cry, they become so irritable. You may not even be able to sleep because they are not sleeping in the night. At times when you feed the infants, they will not take. You could also see maybe reddening at the point of the injection. Must there be a reason why at any point in time we would not take our kids or our infant for vaccination? No. So it became a welcome news when Ghana Health Services with partners on the 2nd of June intimated that we are going to have the HPV vaccination included in our EPI program. But with modernism, there are a whole lot of discussions around whether I need to take my kids there because I think that the vaccines are now not good for our kids, and it's associated with autism, it's associated with this and that. The plain truth is that science have moved to the point where it answered a lot of issues that we had. If nothing at all, take paracetamol and penicillin. That has done us so much good. We can talk about COVID. As to whether COVID, was good with us in terms of the interventions that we did, protected a number of us. This is quite a rhetorical question we need to answer. So in that pursuit, with the knowledge I have, I came up with stuff that would lessen our uncertainties that we have when we intend to have either a single or multiple cohort of young people we want to vaccinate. The most important person has to do with a parent and the one who intend to give the vaccine, the health worker, and then the parent. So the question was, if we have the vaccine supply, is that good enough to secure the kids from the disease we want to protect them from? And from my assessment, it was no. The most important person has to do with the health care provider and the parent. And that reason has been what we are here today. We've realized that from 2015, for countries that had already been conscripted onto the vaccination protocols, the concerns that mothers have, the concerns that parents have in general, the concerns that people who are key in the discussion on the vaccine has to do with whether they are safe for our kids. Majority of the discussion are coming from the fact that we don't have much information about how good these vaccines are. We don't have much information about how bad our situation will be if we don't have these vaccines. And I can tell you, from the little we've had so far, you need to know that the vaccine is an absolute protection when you've never had a contact with a bad one in the society, in the population. I'm using the term the bad, which means the wild type, the naturally prevalent type of the HPV, the one that causes or can lead to cancer. That natural one, when it comes to our kid, that is when they have a contact, whether it's through sex or whether it's a vertical transmission, let me put it that way, then the vaccine may not be effective. So at what time can we be lucky to often have a cohort of naive kids that is in our upper primary? Because around SS1 and SS2, majority of our girls get exposed to the wild type. And when they are exposed to the wild type, then the one who will come in to protect cannot work or become ineffective, because the vaccines are produced by mimicking part of the wild or the already prevalent virus that causes the cancer. So we tend to, let's say, scientifically engineer something that looks like the bad virus. And then based on that, we are able to trick the body to produce army soldiers against the wild one. We use a picture, let me put it this way. We use a picture of the one that causes disease to produce soldiers that can attack the one that causes the disease. So it's an non-infectious way of mimicking or producing a template that can effectively protect us in the future. The immunistic response or the immune system works by recognition. So now, the one that can cause me the disease, I want to take a photograph of that, go into my factory, based on that, produce an army that will be ready to fight when the wild one comes in. And that is the principle being used in terms of the HPV vaccination. It's intended to be used for both male and female, but for supported, let's say, funded projects like what is coming through the WHO, the Gavi initiative, is solely targeted at girls. The reason being that when we are able to vaccinate girls at certain coverage, the protection extends to the boy. It's unfortunate that is what we need to do now, because it's quite cost prohibitive. As a country now, we need a lot of support. And up to from the inception of the EPI, the Expanded Program of Immunization, we've had a lot of sponsorship from a lot of global bodies. Thick into the specific, we call them the Gavi initiative. It's quite expensive. And then again, they often target populations that at the end of time, when they wean you off from the support, those producing the vaccine will also be able to recoup a bit of their money. Last year was Bangladesh. Last 2 years were Bangladesh and Nigeria because of the size. And then the fact that the current global agenda is to prevent these cancers. And that if we need to do that, it would also protect the resource endowed societies from them having any issue from the global south. So if I can take them again, it's a world strategy for us to protect our population against HPV related condition, which is not just limited to the perineum or the shame area. It can be on your skin, on your throat, and everywhere, even on your eye. Now, if that is the case, you should know that the vaccine should not be seen as something that would expose our kids to things we don't expect them to do. It's rather thinking that when they are old, they will not have an issue of having cancer on any of these parts of the body. And then they should know that when it happens like that, or if this 22-year-old girl had had the vaccination, she might not have been, dead by now. And you need to know that when we talk about the safety of the vaccine, there are several things that have been done since 1997 up to now. These studies span over 20 years for both real life and then, let's say, research environment findings. And I should be able and confidently tell you, the same issues we had with the vaccines when we take our babies to the mild pain that causes them their discomfort because they can't talk, the mild pain that causes them the irritability because they can't talk, is the same thing that happens when you take the HPV vaccine. At this age, my 9-year-old girl should be able to tell me that I'm not feeling well because she has the pain. And this, in terms of parents, we've been able to do well when we take them for this vaccination or immunization. When we come back, we give them paracetamol. When we come back and then maybe the arm is swollen, we have a way to put on cold compress. These are things that we are armed already. Our journey from the inception of EPI up to now, can anyone say, I sent my kid to, let's say, weighing and then I lost my baby the next day? Would you want people know what nkonkon is, whooping cough? People know what tetanus is. Those people who lived in the hippie period, late 60s to early 70s, they know very much when we never had any population-based intervention to prevent tetanus, whooping cough, pertussis, measles. And these are the pictures we need to have in mind. The skepticism, the mistakes that people would want to kind of throw in our eyes, and that this is this and that. Please, it's not something we need to listen to. And for me, the gains are such that we will still not, if nothing at all, this 22-year-old girl, it could be just a debut sex, but gotten exposed to all the wild types. Now, that baby girl or that university third-year girl who would have probably be working to support the family now is not around. The same way, we can talk about the fact that the diseases globally that is being attributable to HPV, whether it's a male sex or female sex, is quite substantial. The vaccine is very safe. Based on clinical and real-world data, we don't think that someone has had any serious deformity for having the virus. What prevents us from protecting these adolescents to become, healthy mothers and fathers? Thank you. At this point, I'll be ready to answer any question that anyone brings. The first question that I have in the chat session was, I read that adults up to 40 years can have the vaccine. I would be very tactical in answering this question. The target population is 9 to 15 years. So please, I hope the person is listening. So now, for this group, for us to increase coverage, people who we intend to protect, we want to give them 2 shots. There's something with immune response. The younger you are, the best the response, and then the memory established by the response. We depend on so much memory. I've recognized this thing before. I've seen this before. So when anything in that, my loop pops up, I should be able to protect. But you can also realize that from 9 to 15, there is a group of 9-year-olds, a group of 10-year-olds, a group of 11-year-olds, a group of 12-year-olds, a group of 14-year-olds. Granted, someone started the vaccination around, let's say, 12 years. In a typical multi-cohort protocol, it means that by 15 years, the person might not have finished the vaccination schedule. In that case, we need to catch that population up. So we would extend it. Someone genuinely may not have missed the vaccine, and then that age bracket is off for the person. So we need to catch up. In that case, there's an allowance for you to do the catch up to 26 years. It's true, it can be extended at 45. But hey, sexual activity or contact with a wild type reduces the efficacy of the vaccine. So the longer you wait, the likelihood that that person is not going to even have any benefit from the vaccine. And this is a case where you don't ask whether someone is a virgin before you give the vaccine. So it's an individual stuff. If you think that at 40 years, you are coming for the backup or the catch-up, then it's up to you. You may not get any benefit from the vaccine. So the population-based and per what we're doing at the moment, we think that the cohorts between 9 and 15 years are our target. We are also open to what? Catch up when those miss or they don't complete it because they go beyond the 15 years. And then the next thing is, please, my daughter will be 9 years on the 17th. Can the person? Yes. You see, for these vaccine protocols, the best outcome is when the person is young. the truth of the matter is that there's always a gray area. The vaccine as it is cannot have any detrimental effect. Someone is paying for the vaccine. And then again, the target, being able to define the target population makes us able to have like a more refined or a more defined way of doing and having a uniform spread, being able to have an equitable, distribution of the vaccine. For someone turning 9th, 17th, 9th in the service still belong to that cohort. Because if we want to give the vaccine, often we deal with cohorts. So this start from year 4 in primary school, possibly up to 3rd year at the JHS. So we are targeting the cohorts. Not everyone will be dead right 9 years. And it would be a bit before 9 years or a bit after 9 years. There are a few questions. That the next question, please, why is the vaccine directed at females? Better, it's a policy. It's not directed at females per se, but it's known that the cost effectiveness in terms of achieving a herd immunity, you can achieve them with having certain percentage of females, vaccinated. If we had a lot of money, if we were the people buying the vaccine for us, it would not matter for men also to be part of the normal vaccination, protocol. For now, we realize that cervical cancer and then let's say penile or anal cancer, which of the numbers are high? It's cervical cancer. So everyone will place the money at where the most issues are. And that's the reason why the considerations are often around the fact that let's target the female who has enough or higher numbers of the condition that is featuring in the discussion. Please, I may have missed, but please, when and where will the vaccine be available? I guess we are having a school-based vaccination. Let's say, or let me put it this way. The Ghana Health Services, because majority of the targets would be in school vis-a-vis the free basic education system, most of the information for where you can have the vaccination is being given through the school. My daughter, who also qualifies, will be giving the injection at the school. So the school, in liaison with the Ghana Health Services, for some of the schools, they are sending out reminders and then permissions to parents for them to allow their kids to have the vaccine within the school. But I think that as part of the EPI or the expanded program of immunization, it's a very detailed network. If we have a database for those in school will be catered for. People marginalized population, for example, let's say adolescent living with HIV, we know we can meet you at a chest clinic. For those nomadic population, those that the Kayayos, we know where we can meet you to give them the vaccine. For the typical pastoralic, let's say those, or let me put it, those around the hard to reach areas around the Volta Basin, we know how we can reach them. So I think that is something you can trust the Ghana Health Service on in terms of the immunization we want to give to the girls in this age group. Yes, the vaccine would is a lifelong protection. The earlier you have the vaccine, the better your immune preparedness to fight later conditions that may come on because of what vaccine, the HPV virus. It's lifelong. For those under 9 to 15 or under 15, you need just two. There is even a single vaccine that is being, developed. It's been tried in other populations, and I think that it's all geared towards the fact that we want to have good compliance. We want to have higher coverage. So if someone need not to come for a booster, then it means that we would be able to kind of give a lot of people let's say protection against the HPV virus. Please, are private schools also targeted? Yes, please. It's a Ghana health, Ghana government intervention, and that is not limited to any schools. I am aware that a lot of schools currently have been informed by Ghana Health Service, and that everywhere the child is, so long as the person has meets the requirement, that child will be given the vaccination. Yes, can Na Adole, you have your hands up. Is there a question you want to ask? Is it a
There's a comment I want to make concerning the question that if you want, if not, how do I get my daughter vaccinated? So if for one reason or the other, your school is not enrolled, your child's school is not enrolled, which I don't expect, all the public health units of the hospitals would have vaccines, so that if for any reason the child is not vaccinated at school, then you can send the child to Konfanoche, Menchia, all the facilities in Kumasi would have vaccines, so that if you have to send a child, I think that it's accepted. But I think the school is the target. Thank you.
Yes, Bertha.
Good evening, Doctor. Thank you, Doctor. Thank you, the colleagues or friends on this line. Doctor, as far back as, should I say 10 years ago, I heard about this virus and I wanted to vaccinate my 14-year-old daughter. But I was told that since she's not sexually active, it's okay for her. Listen to you now, it's a different story. And after that, yes, this is my second time hearing. I believe the education is very low. Can we take it to the media so that the education will be more widespread? Thank you.
Yes, thank you, Sister Bertha. And as I said, there are a whole lot of half illiterates who are rather propounding the stories about HPV and all that. Capacities we had as country was not ripe to the point that people would have let's say unbiased information about what I'm talking about. We must be very careful. We are mothers, we are fathers, we are stewards. The information is we are protecting our future daughters, our future's mothers and fathers against all diseases. HPV should never, although it's sexually transmitted, issues around it are not discussed in the milieu of what sexual promiscuity or someone who is having sex or not having sex. And that should be the first thing that should pop up. No parent will be comfortable, let's say, protecting the daughter or the son against something that the person will have through sex. Because I know my daughter, I know my son is not having sex. That should not be. That's a bit defeative. The approach, I would just want to add on to Nadole's comment. The approach is that, or the discussion has been centered on the fact that majority of the cohort or the target we have for this population are within the upper primary and then the JHS. And that's the reason why differentially we have to use the school-based approach as the main. But at the end of time, we understand that there are squatters in your area that they don't go to school. There are people who are passing through Kumasi to go to Yeji, who will spend time sell with their money, they don't go to school. It must be said that the health system setup, okay, we have provision for everyone in terms of these transitory populations. It's just not about the school, it's everyone, so that the coverage will be high for us to have a protected population. Thank you. On that note, I guess there are no other questions that I need to address. I thank you for your participation. And then, please, I'm hearing Kumasi a lot.
Please, one last question, please.
Okay.
Good evening. Please, how many shots are they supposed to? Is it a one-time shot thing, or it's in stages, maybe in
okay.
the vaccine?
So if your schedule, or let's say hello. The first consideration is that you need, if you're less than 15 years, you need 2 shots. You need the baseline shots and then the booster. But know that as we go on with the experience from other people who have rolled up a population, we now feel that if we ask you to have the shot and come back again, some of them will not come back. So there are other people who are considering 1 shot as the model they want to use. But for us in Ghana, for those less than 15 years, you need 2. If your schedule is not completed within your 9 to 15, then we'll look at the other schedule, which is about 3. You need 3 doses. Okay, that will take you up to like 26. That covers something called the catch-ups. So the catch-up for those that could not complete their schedule, or for those that missed their schedules. So these are things that are well taken up or well planned with, along with what the schedule is. So now for 9 to 15, you need 2. If you don't complete it within this time, you may not need only 2, you may need 3. And then there are considerations for us to have a single vaccine, but probably it's not within this bit of the discussion.
Okay, thank you. Please, this is just a follow-up. So what are the intervals for the shots?
So 0, okay, month, and then if it's 3, 6. So you have it today, you can have it 0 to 6. That is often when for you to have the best response. You have it today, in 2 months they repeat, and then 6 months. That is the typical protocol for the HPV-based vaccination. So for us, it means that we will give you, if you came today, they give you today, in 2 months' time they will repeat. But when it comes to these things, there are a bit of flexibility in terms of maybe you may delay for about 3 or 4 days because there's a population we need to kind of satisfy everyone. But the most important thing is that there's a range of time we need to give these vaccinations.
Okay, still here, please. Since we are this is for the students and they are in school. So should they? Sorry.
Yet one. Let me just comment on it.
I'm giving a follow-up. So if you could please let me land. Thank you.
Okay.
So please, what I'm saying is, if they take the shot and
Yeah.
maybe able to they go on vacation before the next shot is due, what do you do? Would you wait for them to come, then you give them the shot, or maybe there is some window period that could cover them?
Yeah, that's a very important question. Thank you. You see, I did sorry, the school-based thing. It's not. It's a hybrid of a whole lot of fun. Okay. The system, the database is such that it captures a lot about the recipient, and then they know exactly how they will prepare the cocktail, or let's say the approach or the modality for maybe the rage students, maybe for, let's say, the Nyami students. They know exactly what they are going to do when it comes to these things. They will plan a such that our kids will not miss out on them. If there's a reason why they have to alter the model, then provisions will be made. You may have to go to your nearest health post to continue or something, because it comes in. There's a paper I think you're gonna have, and then let's say there's a card you're gonna have or something like that. That would direct you as to where you can have the booster dose. Now it's back. Now let me hear what you have to say again.
Dr. Amo-Antwi, I've just clarified with the Regional Health Directorate.
Okay.
They are using the WHO model, so they are going to give just one vaccine.
Okay. So now there's a single vaccine. Okay, that's
Yes.
okay. So now there is a one dose vaccine, the one dose
Vaccine.
protocol, the 2-dose protocol, and the 3-dose protocol. We are lucky,
Yes.
and we are lucky we have the single dose. That's very important.
Yes, so we have the single dose. That's what we are going to use.
Yeah, that's important.
Yeah.
Thanks for the information.
Thank you. Thank you too.
Betha.
Doctor, one last question. So, I've heard you said the target audience is our teenage girls. But please, for older women above 50 years, isn't there any hope for us? Doctor, don't laugh.
Yes, see, we're banking so much on the naivety of the immune system. The more naive the immune system is to what we are protecting against, the better your chance of achieving the best from the intended protection. Now, at age 50, I don't now you people, you see, people talk about the vaccine giving protection to a certain group of the population outside this target. But the fact is that from where I stand and what I know about the HPV in terms of the cervical cancer carcinogenesis or cancers of the other, I don't think at that age you're going to benefit it. Literature is so little and scanty when it comes to these things. The best model for those around this age group is to go through the screening protocol. The screening is to find out whether, based on the fact that you've gotten already exposed to the HPV in the wild population, has it gone to have any changes on your service? That is what we need to look for. And then if there are any changes on the service, then we manage them as such, but they are not within that group of having the vaccination.
Thank you. Thank you.
Mrs. Opariado. Professor,
yes,
sorry, I missed your call.
Dr. Amo-Antwi, I'm the same now, really.
Okay.
I noticed you didn't know it was me.
Okay.
So, okay, so parents and friends, would like to say a big thank you to Dr. Amo-Antwi for enlightening us. I believe that we are ready to get our daughters vaccinated. And we are ready to go out there and convince those who are not sure to get their daughters vaccinated. Personally, this is very dear to me. I think that this is long overdue. And so if we are lucky and we've been enrolled on the WHO program and we can vaccinate our daughters, let us take advantage of it. Thank you all for joining and be our advocate for our girls to go for the HPV vaccine. Okay, so another thing I confirmed was all the centers again will have the vaccines. So if for one reason or the other you miss out 7th to 11th October, you can still walk into any of the public health units. Okay, good. So thank you so much for joining us, and thank you so much, Dr. Amo-Antwi. Have a blessed evening.
And
bye for now.
We are even ready within the period if we need to repeat this same discussion.
Okay.
Thank you.
Okay.
Yeah.
Thank you too.
And there are a few things that I may have to say in ramping up. We acknowledge the input of the School of Medical Sciences. Then Albright Cancer Foundation and then Walter Aiden Specialist Hospital. In a sense that we're trying to establish a capacity for the management of cancer of the genital tract of females and then childhood cancers. And these are a dream that we would want to actualize in the next few years ahead. Thank you all.
Thank you so much. Have a pleasant evening, all of you. And thanks for joining us. At a point, we were about 65, and I think that was a good number.
Yes.
Yeah. So thank you so much.